Welcome to this educational program.
This module discusses the risk factors for acute coronary syndrome, or ACS, a set of 3 heart conditions resulting from the process of the hardening of the arteries called atherosclerosis. This information is taken from a recent review of the medical literature and attempts to be as transparent and comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or skip through them in any order you wish. Acute coronary syndrome, or ACS, is a set of 3 heart conditions: unstable angina, a type of chest pain, and 2 types of heart attack, called NSTEMI and STEMI. NSTEMI stands for non-ST elevation myocardial infarction, while STEMI stands for ST elevation myocardial infarction. These conditions usually result from the hardening and narrowing of the arteries, a process called atherosclerosis. A disease risk factor is something that increases the risk of disease. Not only can a risk factor make you vulnerable to illness, but can also worsen other risk factors, creating a complex network of contributors to ill health. Though some risk factors cannot be modified, it is possible to reduce the risk of disease by modifying those factors we can control. Atherosclerosis is thought to begin with damage to the innermost layer of an artery called the endothelium. Damage to the endothelium results in the influx of cholesterol and various other cells and molecules into the endothelial lining, a dangerous buildup of fatty substances in the artery called a plaque, and the initiation of an inflammatory response, or inflammation, a series of events in the artery that further contributes to and actually speeds up the process of atherosclerosis. A buildup of plaque will eventually prevent sufficient blood flow from reaching the heart muscle. Over time, the plaque can actually rupture and expose a surface upon which a blood clot can form. Obstruction of the artery from this blood clot can then lead to the conditions of acute coronary syndrome. While atherosclerosis occurs naturally to some degree in all individuals, it is worsened by certain risk factors. Some of these risk factors can be modified, and some cannot. Risk factors that we cannot change are called non-modifiable risk factors. Those that we can change, generally by making healthier lifestyle choices, are called modifiable risk factors. Non-modifiable risk factors for atherosclerosis include age, gender, ethnic background, menopause, and family history. Now, let's look at these risk factors in a bit more detail, beginning with those that cannot be modified. Though heart disease can strike at any age, men over 45 years old and women over 55 years of age are more at risk for atherosclerosis. In general, symptomatic coronary artery disease occurs about 10 years earlier in men. About 85% of people who die from heart disease are over the age of 65. With respect to gender, men have a greater risk of atherosclerosis than women. And though women's risk does rise after menopause, the permanent end of menstruation, it doesn't seem to reach the higher risk level of men. Regardless, this by no means implies that women are not at risk for heart disease. Women's atherosclerosis risk rises more slowly if menopause occurs naturally, and more sharply if menopause is induced by surgery to remove the uterus and ovaries. Clinical trials are currently underway to help better understand the possible benefits of hormone replacement therapy, also called HRT or ERT, for menopausal women and their heart disease risk. Compared with Caucasians, heart disease risks are higher among African Americans, Mexican Americans, First Nations, Native Hawaiian, and some South Asian populations. Finally, increased risk of atherosclerosis can be due to your family medical history of premature atherosclerosis, before 55 in men, or 65, or menopause in women, heart attack, angina, stroke, or the tendency to develop high blood cholesterol, high blood triglyceride, fat levels, high blood pressure, or diabetes. Modifiable risk factors include smoking, diabetes and insulin resistance, high blood sugar, hypertension or high blood pressure, poor diet or obesity, raised LDL cholesterol, the bad one, and/or reduced HDL cholesterol, the good one, high triglyceride levels in the blood, and elevated C-reactive protein, or CRP, or homocysteine levels in the blood. Also considered here are hemostatic or blood clotting factors, personality type, and emotional stress. The next few slides discuss the modifiable risk factors for atherosclerosis in greater detail. Not only does smoking decrease HDL cholesterol and increase LDL cholesterol in the blood, but it also increases the concentration of carbon monoxide gas in the blood, which may increase the risk of injury to the endothelium. It causes arteries already narrowed by atherosclerosis to constrict more, further decreasing the amount of blood reaching the heart and other tissues, and it increases the blood's tendency to clot, increasing the risk of artery obstruction by a blood clot, leading to unstable angina and heart attack. Furthermore, tobacco smoke is directly toxic to cells. It can cause the arteries to spasm, and it increases arterial inflammation. A smoker's risk of developing coronary artery disease is directly related to the number of cigarettes smoked daily. Secondhand smoke, the smoke breathed in from someone else's smoking, also appears to increase the risk. It may seem incredible, but those who quit smoking for even 1 year have only half the risk of heart disease as those who continue to smoke, regardless of how long they smoked before quitting. The benefits of quitting begin immediately and increase with time. After about 3 years of quitting, the risk of coronary artery disease becomes similar to that of people who had never smoked. It is important to understand that many effective programs, nicotine patches, and other medications exist to help a person quit smoking. Diabetes is another important modifiable risk factor. Diabetics do not properly produce or use insulin to take up glucose, or sugar, into its cells, resulting in a high level of glucose in the blood, called hyperglycemia. Hyperglycemia can affect the function of arteries by increasing the leakiness of the endothelium to allow toxic substances in the blood to get in, increasing the level of oxidized LDL, and increasing the level of arterial inflammation. Atherosclerosis occurs earlier and more often. In fact, the risk of developing atherosclerosis is 2 to 6 times higher in people with diabetes. Atherosclerosis is the cause of death in 75 to 80% of diabetic patients. High blood pressure is another risk factor for atherosclerosis. Blood pressure results from the force of the heart pumping blood into the arteries, and the force of those arteries resisting blood flow. Arteries that remain constricted and less flexible can cause high blood pressure, hypertension, which makes the heart work harder than normal, causing it to enlarge, weaken, and become more prone to injury. Inside the arteries, hypertension disrupts the lining of the vessels called the endothelium, increasing its permeability or leakiness to contents of the blood and increasing the risk of arterial plaque buildup. Blood pressure is measured in units of millimeters of mercury, or mmHg, and is represented by 2 numbers. Systolic pressure, the higher number, is the pressure of the blood flow when the heart beats or pumps, while the diastolic pressure, the lower number, is the pressure of the blood flow between heartbeats when the heart rests. The harder it is for blood to flow, in other words, the narrower the arteries are, the higher both numbers will be. In adults, high blood pressure is defined as a systolic pressure of 140 or higher over a diastolic pressure of 90 or higher. Normal is considered to be a blood pressure of less than 120 over 80. Diet is a risk factor for atherosclerosis because it plays a role in the levels of cholesterol, triglycerides, salt, and sugar in the blood, and contributes to obesity. A diet low in saturated fat, trans fat, cholesterol, and refined carbohydrates can lower levels of LDL cholesterol and raise levels of HDL cholesterol. Saturated fats include butter and margarine, cream, hard cheese, processed meats, coconut and palm oil, chocolate, cakes, pastries, and snack foods. Trans fat, a processed fat that does not occur in nature, is found in donuts, breads, crackers, potato chips, cookies, margarine, and salad dressings. And refined carbohydrates, foods that have had the fiber removed from the grain, include white rice, white bread, sugary cereals, and pasta made from white flour. A diet low in salt will help prevent high blood pressure, and limiting sugar can help preserve the functioning of the endothelium and prevent increased levels of oxidized LDL. While limiting these substances, One should strive to take in adequate amounts of antioxidants, omega-3 fatty acids, and fiber. Cholesterol is transported through the blood by carrier molecules called lipoproteins. High-density lipoprotein, HDL, is known as the good cholesterol. A lipoprotein, made largely of protein, HDL removes excess cholesterol from the blood. Low-density lipoprotein, on the other hand, or LDL, is known as the bad cholesterol. If too much LDL circulates, it can slowly build up in the walls of the arteries and contribute to atherosclerotic plaque. Furthermore, oxidized LDL, LDL that has undergone a chemical change, can also trigger an inflammatory response. An excess of cholesterol in the blood, called hypercholesteremia, is a well-known risk factor for heart disease. Though cholesterol is an important essential nutrient used to form the outer coating of cells, called cell membranes, as well as hormones and other needed tissues, too much cholesterol in the blood can have dangerous consequences. Although all the cholesterol a body needs is produced by the liver, excess cholesterol comes from animal products such as egg yolks, red meat, fish, poultry, seafood, and whole milk products. Plant foods do not contain cholesterol. Cholesterol levels increase with age, with a high-fat diet, and with certain hereditary disorders. They are normally higher in men than women. C-reactive protein, or CRP, is a type of protein found in the blood, released only in response to inflammation and not normally present in the blood of a healthy individual. Inflammation occurs in response to injury and is central to the endothelial problem underlying atherosclerosis. Therefore, the presence of CRP in the blood can indicate atherosclerosis. Triglycerides are a class of lipids, or fats, in the bloodstream and in all the cells of the body that come directly from fat in the diet and from carbohydrates that are not used immediately for energy. A high triglyceride level, called hypertriglyceridemia, combined with low HDL cholesterol or high LDL cholesterol, seems to speed up atherosclerosis. Homocysteine is an amino acid, and high homocysteine levels have been shown to contribute to inflammation and the development of blood clots in the arteries, and are a strong predictor of poor outcomes in patients with coronary artery disease. Levels of blood homocysteine can increase with age, certain disorders, such as homocystinuria, kidney failure, some cancers, and psoriasis, heavy smoking, the use of certain drugs, and dietary deficiencies. Obesity, the condition of being more than 20% overweight, is a major risk factor for atherosclerosis because stored fat, especially around the abdomen, directly impairs endothelial function and is associated with arterial wall thickening and is a trigger for inflammation. Indirectly, obesity aggravates another risk factor for atherosclerosis, insulin resistance, which also impairs endothelial function. The first recommended way to estimate a person's body fat are the body mass index, BMI, and waist circumference measurement. BMI assesses a person's body weight relative to height and correlates highly with body fat in most people. To measure BMI, take a person's weight in kilograms and divide it by their height in meters squared. For instance, if your height is 1.82 meters, the calculation will be 1.82 times 1.82, which equals 3.3124. If your weight is 70.5 kilograms, then your BMI is 21.3, 70.5 divided by 3.3124. A BMI value of less than 18.5 is considered underweight. A value of 18.5 to 24.9, healthy, 25.0 to 29.9, overweight, 30.0 or greater, obese, and 40 or greater, morbidly obese. For waist circumference measurement, or the distance around the waist, a high-risk waistline is more than 35 inches for women and more than 40 inches for men. The second recommended way to estimate a person's body fat is to measure so-called visceral obesity by an estimated waist circumference and waist-to-hip ratio measurement. The recommended waist-to-hip ratio for men is less than 0.9 and less than 0.8 for women. In regards to waist circumference, you are at a high risk if your waist measurement is more than 102 centimeters and are male, or more than 88 centimeters and are female. Metabolic syndrome, also known as Syndrome X, is a cluster of conditions that when occur together, dramatically elevate the risk of heart disease. The conditions include elevated triglyceride levels, insulin resistance, abdominal obesity, elevated blood pressure, and low HDL cholesterol. Metabolic syndrome is a pre-diabetic condition that is significantly associated with heart disease and higher death rates from all causes. An inactive lifestyle is also a risk factor for heart disease. People who remain inactive are almost twice as likely to suffer heart attacks as are people who exercise regularly. Exercise has a number of beneficial effects, including improving cholesterol levels, diabetes, and high blood pressure, reducing inflammation in the arteries and assisting weight loss. It has been shown that cholesterol and lipid levels can be improved even with low amounts of moderate or high-intensity exercise, though more intense exercise is required to significantly change levels. Resistance, i.e. weight training, also has been associated with heart protection. There are many things you can do to decrease your risk factors for acute coronary syndrome. Stop smoking, eat a more balanced and healthy diet, and exercise regularly. Remember though, it is important to check with your doctor before making any major changes in your lifestyle, just to be sure you are doing so safely. Your doctor can also help you monitor your success by measuring blood pressure, BMI, and blood levels of cholesterol and triglycerides. In summary, acute coronary syndrome is usually caused by atherosclerosis, or hardening and narrowing of the arteries. Certain risk factors exist that contribute to weakening of the inner lining of the arteries, called the endothelium. This leads to plaque formation and inflammation. Some of these risk factors can be modified or changed, while others cannot. To summarize, the risk factors for atherosclerosis include smoking, high blood pressure, high cholesterol, high triglycerides, diabetes, poor diet and obesity, sedentary lifestyle, metabolic syndrome, high CRP and homocysteine, emotional stress, anxiety, and non-modifiable things such as age, gender, ethnic background, menopause, and family history. You can make a difference and decrease your risk factors for acute coronary syndrome. Work with your doctor to come up with a plan that is right for you. Here are just a few of the many resources available to educate you on the risk factors associated with ACS. These references are also available through the internet or your local medical library, should you desire more detailed reading on this subject. We sincerely hope that this module has furthered your understanding of risk factors for acute coronary syndrome. Other modules are available that will help you understand this condition further.
We wish you the best for the future, and thank you once again for viewing this educational program.